You were muted.
Gotcha. Did you guys hear me? I stepped over again. I was muted. Anyway, if you guys didn't hear me, thanks for spending your night with us. This is Dr. Carls. I was just saying that soft tissue, we want to be kind to soft tissues when we're operating. It's for a multitude of reasons, and I want to go over why and why we use techniques that we do and some examples. And then I'd love to open this up to questions. Anyone has questions, or possibly some of you guys are awaiting surgery and want to know a little more about it. But this is for you. So why do we use minimally invasive surgery? Again, it's kind of the soft tissue. It's much quicker rehab. It allows us to work out of outpatient centers better. In the old days with these large incisions, of course, hospitals, we would keep patients in hospitals even for say a routine total knee replacement for 5 days. And that was only about 20 years ago. It's kind of unheard of now unless someone's very unhealthy. So things have really changed. I want to go over some examples and common diagnoses. I also basically expectations for post-surgery and what you can expect afterwards, that type of thing when you get back to normal activity and kind of the average patient population. So there are different types of minimally invasive surgery. The kind that most of you have heard of is whenever we talk about doing scopes. Every specialty does it, general surgery, GYN, we do, everybody does it. We basically will pump normal saline, sterile of course, into your joint to open it up. And that's how we get our little instruments in there. And we can do a lot of work. We have these amazing high def cameras and, we have these great monitors and we can see millimeter. I mean, just, tiny little things. And so it's extremely accurate. And we go in through these tiny little poke hole incisions. We also, in orthopedics, do a lot of fractures, of course, and we use a lot of percutaneous techniques, we call them. Basically little poke hole incisions where we can put in pins, screws, little plates. We can use instruments like these tong type things that we kind of can bring the fracture together. And this is also great because when you have a fracture, your soft tissue is already irritated. It's already swollen. So if you make a large incision, it just irritates the area more and causes more, problems, more chance for wound breakdown, things like that. So percutaneous techniques have really come a long way with all kinds of, mostly in our fractures, but we use it for reconstruction all the time. We usually use fluoroscopy along with it. That's a real-time X-ray. Looks like we call it a C-arm. We bring it in and you can see everything you need to see. It's amazing. It's real time. So we push on the pedal. You can see exactly what you're doing at that point in time. You know exactly how far you're putting the screw in, that kind of thing. The other minimally invasive surgery that we have been getting better and better at is with total joint surgery reconstruction. Whether it's ligament reconstruction that we use a lot of in sports, such as ACLs, in knees is one of the most common. And in arthroplasty, of course, in knees, when you're doing a partial knee replacement or even a knee replacement, incisions have been getting smaller and smaller. Same with hips, and same with shoulders. And I do shoulder replacements. I used to do a lot of knee replacements, not much anymore, but there are great techniques that we use for arthroplasty as well. It's the same thing. We talk about minimally invasive. It means smaller incisions, faster rehab, less complications. So basically, again, we use it because it's minimal blood loss, less pain and swelling, faster rehab, and we can use outpatient centers and do outpatient surgery much easier and safer. And plus, especially using surgery centers, surgery centers, because they are not trauma centers, are generally very clean. They're very efficient. The teams are generally very well trained, and we all work together all the time. So surgery centers have really in the last 20 years have really boomed, and they will continue to boom because the better we get, more efficient we get. It's better for the patient, it's better for us. Um, and so all the minimally invasive stuff that we've come up with has really helped us evolve into more outpatient surgeries. The other thing is, of course, anesthesia has evolved. And they do a lot of what we call regional blocks. Regional blocks, allow us to do more outpatient surgery, thanks to the great anesthesiologists that we have working with us. So then we start looking at, the typical conversation you have with your doctor: is surgery right for you? Typical thing, of course, is, non-surgical treatment isn't working for you. We usually try everything. In orthopedics, we use a lot of injections, of course, a lot of types of injections, rehabilitation. Sometimes, however, if, say, it's a really big tear in your shoulder or knee, especially if you're an athlete or very active person, we tend to get more aggressive and want to move more aggressively into surgery in many cases, because we want to get you back to your activity. We always say in orthopedics, we don't save a lot of lives like cardiothoracic surgeons do, but we're there to help your quality of life. That's what we like to look at ourselves as doctors, that try to keep you active. And active, moving is life. And so that's what we're here to do. And so if you're a very active person, we don't want to see you just continue to stay kind of on a plateaued situation with rehabilitation. If it's not going anywhere, then we start talking more about surgery, especially if you have specific tears that we fix very well. We'll talk about a few of those. I'd like to talk about a few examples that I'd like to talk to you about. We can start with the shoulder. That's the most common thing that I take care of these days. Rotator cuff tears are very common in an older population. We always say that over the age of 40, we really start to see a uptick in incidence of rotator cuff tears, and it has to do with aging of tendons as we get older. The blood supply is not as good, so little micro tears that you might have been able to heal when you were in your 20s, you just don't when you get older. Just like an old piece of rubber sitting out, in the sun, everything gets a little brittle. And of course, you can stay in great shape as you can by, eating well, trying to stay limber, stretching, things like that. I don't think adults do enough stretching or warming up for various activities, but bottom line is we see rotator cuff tears start to increase at a certain age, and generally over the age of 40, we really start to see an uptick in it. Also in shoulders, we have athletes, if they dislocate their shoulder, they end up having an instability problem where you basically tear an important cartilage in your shoulder called a labrum. And so we do a lot of fixation of that through the scope as well. It's called a Bankart repair. We do many of those in athletes, very common problem. Of course, arthritis and cartilage loss. Arthritis, of course, gets more common as you get older. We know it has a genetic predisposition, especially in osteoarthritis. Rheumatoid arthritis or other type of inflammatory arthropathies, we see too. Sometimes we need to clean it out. Sometimes we need to smooth off a cartilage that basically has a big flap and is causing what we call mechanical problems. These mechanical problems in catching lead to pain, swelling, and loss of motion because you don't want to move because it hurts. There are also, when you break off cartilage, you can have what are called loose bodies. Basically, these little pearls start floating around the joint, and they wreak havoc. You can feel them. Patients sometimes come in and say, "Doc, I feel this thing," and it moves. And you get an X-ray, and there's a big loose body, big chunk of bone or cartilage has been floating around there for a while. So that happens. Spurs from arthritis happen for reasons that because your cartilage is going bad, your joint is going bad, your body tries to expand the size of the joint to increase your weight bearing to try to make up for it. And you get these things that we call spurs or osteophytes. They can break off. They can also rub on ligaments. And all the stuff that I know most of you guys know about. If you have arthritis, you're living it right now. Fractures, we do a lot of fracture work now where we also use a scope. And arthroscopy, along with percutaneous techniques, have really changed a lot of what we do in trauma. It's especially saying something called a tibial plateau fracture. If you break through the top of your tibia and it goes into the joint, we often use a scope so we can gauge our reduction of the fragments. While from the outside, we're actually pushing up on the fragment. You can see it with the scope and see that you're well reduced, and then you can, put screws, plates, whatever you need to. So we use a lot of combination things too. In knees, we, I gave that example with fractures. Ligaments, one of the main things we see are ACL tears. If you guys watch a lot of ESPN, you know that ACL tears are very common. PCL tears are less common, but can be very difficult for athletes as well. They're a little more difficult to reconstruct. ACLs are very common, and most of us do quite a few of those in a year, especially around certain seasons. Meniscus tears are very common. I'll show you an example of that. Again, just like the shoulder, arthritis or cartilage loss, loose bodies, things like that, and fractures. At this point, I can start going through a couple examples of things. This first case is one of my rotator cuffs that I did this year. This is basically what's called a supraspinatus tear. There are 4 rotator cuff tendons. There's also a biceps tendon that comes up and attaches in your shoulder. It's called the long head of the biceps, but it also can kind of tear along with the rotator cuffs or separately. A lot of people consider it the 5th rotator cuff, as it does have some physiologic and mechanical things that it does. It's very similar to what rotator cuffs do. So it's sort of like a 5th rotator cuff. But anyway, when we're in the shoulder, this is an example of a large tear in the supraspinatus, full thickness tear. This shows a probe where exactly, and a probe goes through the tear there. So this is from the inside of the joint, this first picture. This is when our scope is on the outside of the joint, but on top of the rotator cuff. And so you can see what it looks like when you're in there, and then when you're pushing the probe through from the outside. And that's what the tear is. That's what a tear is. Very simple. It's the tendon has torn off the bone, and that's very common, one of the most common types of rotator cuff tears. And then you see the last picture where we fix it. Basically, we have great little ways to fix it. Several companies do a great job with this, making these, and we've come a long way in 20 years, but we have these absorbable screws that go in the bone. We don't use metal anymore in general. And there's very strong stitches. If you look at it up close, it's like seatbelt material. Very strong, but very small, and holds the tendon down. In this picture, it's a tape type. We call it a tape, a fiber tape type of thing. And it's woven, and it holds it very well so that you can rehab early and move early. This is a picture of actually my shoulder. Our very own Dr. Thompson fixed my shoulder 2 weeks ago. And I'm doing well. You can barely see little poke hole incisions. He's an excellent surgeon. Anyway, see, basically, this is minimally invasive surgery at its best. So little poke hole incisions. We use these really, high resolution scopes, and we can do a lot of great work. So this is just a very common example. The next example is another rotator cuff tear, where you can see that it's what we would call a high-grade partial tear. And I'm putting a little pin through it. And that little spinal needle, it's called, we use that in a lot of surgeries just to locate. And you can see there's just a few strands left, and in the back, there's like a little hole right there. And you can see that really it's a full thickness tear. So don't let it fool you. This is a rotator cuff tear, and the way we fix it is from staying inside, I put the first screw in that you can see kind of what the screw looks like. It's truly just a plastic screw. And it's attached to those very strong fiber tape sutures. So once we put that into the bone, we put that right next to the cartilage. So it basically makes it as anatomic as possible when we bring that rotator cuff down in that spot. Then when we put the scope above the rotator cuff is the last picture, when we actually bring the sutures through the tendon and then back down into another one of those anchors. This is a commonly referred to as a two-row technique, two-row knotless technique. So there's nothing sticking up to irritate you when you start moving early in rehab. But these are very common examples. The next case we'll show you is, since we're talking about shoulder, is arthroplasty has gotten smaller and smaller as far as incisions and soft tissue, and most arthroplasties now are done as outpatients as well. And by the way, when I say arthroplasty, I'm talking about really joint replacement. If we have a partial arthroplasty, say in the knee, which is common, you're just basically replacing one part of the joint. In the knee, there are three parts, and generally, it's the inside that you're doing that with a partial. In shoulder replacements, these patients represent what we call a reverse shoulder replacement. This is a replacement that's done for a rotator cuff incompetent shoulder. Generally, there are arthritic changes, and we call it something called rotator cuff arthropathy, which means basically you have a messed up shoulder that has a lot to do mainly with the rotator cuff failing, likely years ago. And as the joint is failing, the cartilage starts failing. You have a joint where the ball starts rising high and goes up against the bone that you can feel right over your shoulder, called the acromion. Basically, mechanically, you can't, even if you're very strong, it's very difficult to pull the shoulder up. And so it was a very difficult problem several decades ago. And some very smart surgeons, many of them in France, came up with some of these really brilliant engineering, where now we can take a patient that, say, 20, 30 years ago would have a shoulder that was basically nearly unsalvageable. We tried all different types of things, these very large-headed, we call them hemiarthroplasties, where we put a big ball to try to keep a smaller ball. It tried to replace the smaller ball that we had normally, replace a large ball, so that it would be this enormous joint that would actually articulate off of the acromion. Anyway, not great results. So anyway, this is a phenomenal surgery that we now do. Patients move very quickly. I learned a technique that works very well. It's called a superior approach, where you don't take down the front rotator cuff, called the subscapularis. And even if that isn't present, you're not taking down the capsule, so your chance of dislocating is much less, and much less soft tissue trauma in general. And this technique really lends itself to very early rehabilitation, where basically you can take the sling off in a few days. You start motion just about right away. This is a patient that I did here, where you can see he's moving. This is 2 weeks out of surgery, and he's moving very well. His deltoids are really moving. His deltoids are the big muscles on the outside of the joint that you can feel. And they're able to work because mechanically, when you've replaced the shoulder, you've done it in such a way that the deltoids can work, and they can actually raise the arm up again. So mechanics is amazing. Anyway, you see the incisions there, which are very small. And of course, in knee and hip surgery, the same thing has gone. And we've gotten better and better at it, better systems. We take care of the soft tissue. Again, bottom line is soft tissue, you take care of soft tissue as a surgeon, you're a much better surgeon. It's much better for the patient. The patients rehab better with less problems, less wound problems, less infection, so forth, less pain. So that is minimally invasive. I think, let's see. I do have a few cases to go over with the knee. And then we'll open it up to questions. In the knee, I've got some good examples here include, on the left is you can point to that one right there, Danielle, that's great. It's not coming up on here, but it's coming up on that's great. Okay, excellent. On the first example, this is an ACL repair, which we've been doing a lot more lately. This is, say, a partial, it's best really for partial ACL tears, uh, and generally where the secondary stabilizers such as menisci are intact and other things. But we've been pushing the limit with this more as we have better systems to fix it. But this is kind of a classic example of an ACL repair when you keep the tissue. There's very important nerve receptors in the ligament, so we like to keep the ligament if possible. They're called proprioceptors. They're very important, and we think it's very important for athletes especially. And so we try to preserve tissue when we can. And so this is an example of a ACL repair where you see it's kind of you can see a large portion of the ACL that you can tell that they're fibers and not bad, but it's lax. And this patient had about a 50% avulsion. About half of it was avulsed or nearly avulsed from the femur side. So we were able to repair this nicely. This lends itself, and you can see the stitches there that we use. And on top, that's a reinforcement type stitch that we use. It's a certain technique we use. And so basically, it holds the ligament in the best position possible so that the native tissue can heal. Therefore, you also keep your native nerves, they're called proprioceptors, intact. So really, it's the best case scenario, and we always hope that we can repair these. The next example is an ACL reconstruction. The differences between a repair and reconstruction is the repair, you're just taking the tissue that's there and you're repairing it, like the first example. In a reconstruction, this example is in the top left. You can see in that area, all that's left of that ACL is just a little miserable looking stump. It looks like, a little, I don't even know what, it's terrible tissue. There's no way you can repair that. It's not healthy at all. So we remove the remainder of it and then we repair it. What I've been doing lately, mostly, and most surgeons are going to the quadriceps graft. We take it from you. We take a central little slip from the quadriceps tendon that's right above your patella tendon, and we make a new ligament from that tendon, and it works extremely well. And we put it through tunnels in your bone. And this is an example in the central picture that shows that we have a suture that's coming out of the tunnel that we placed in the femoral side. And then that suture will bring down through another tunnel through the tibial side, the bottom side. And they both have tunnels. And then we, from just under your knee through that tunnel, we bring the graft up through these tunnels. And we have different ways to fix these. Phenomenal ways to fix them, and that's some of the great technology of these companies in the last several decades. We have great ways to fix it. And you see the final picture over there, where that is a quadriceps graft that we made into an ACL, because there was no good ACL to begin with. So that's what we have to do for that. We have to reconstruct. There's many different types of reconstructions. But this has become very popular because it works very well and lends itself well to early rehabilitation. But there are many different grafts. ACL reconstruction in general, you could go to a meeting and it could go on for days. I mean, there are so many ways to do it. It's crazy. Basically, as surgeons, we do what works well for us, what works well what works well in our center and the system we use. But this has become a very good graft. It's called a quadriceps ACL reconstructive procedure with quadriceps, right? The next example is, and these are very common. This is a knee scope. So again, two little poke hole incisions. We go into basically that little, looks like a little pearl up there. That's a loose body. It's kind of partially attached to the joint. And a lot of times they become, of course, they become dislodged and becomes actual loose bodies. And then they can actually kind of get in the lining and become what we call synovialized as your body tries to sort of suck it up and take care of it. But when a lot of these are floating around, you can just imagine the havoc that it wreaks in your joint. I mean, it's terrible. So we go in there, we remove those, we smooth out cartilage. So that's a good cartilage example. That's a very common thing that we do. The other kind of thing that we do a lot is a meniscus Basically, this shows a meniscus tear where the top left picture, you can see the tear. The top right picture, we are probing, putting a probe in the tear, showing where the tear is. This is in the most common area where we see this is called the posterior horn. It's in the back. So it kind of gives you back inside knee pain. It can cause pain when you fully flex. It can lock. It causes pain and swelling. Very common. We see them a lot. See them in athletes. We always see them. We see them in older athletes. We see them in older degenerative knee patients. 50-year-olds. We see them in all age groups. Very common reason for doing a knee scope. You'll see on the bottom left picture, that is that meniscus after we've trimmed out that torn part. We kind of smooth it out. We want to take out the tear because the tear is not doing you any good. The tear is basically dead gristle. It's not going to heal. And it can lock your knee and it causes those symptoms we're talking about. Full flexion causes pain, gives you that unstable feeling. Your knee swells. And so we just trim that out. And patients do very well in general. We want to keep as much of your meniscus as possible because your meniscus is an amazingly important structure. The problem is when it tears like that, it's degenerative. There's nothing else we can do with a tear like this. When it's called a complex tear, it's just shredded. We just kind of saucerize it out. On the bottom right picture, you can see that's the same patient on the outside of his knee where he has a healthy appearing meniscus and cartilage. So you can see the contrast between the two. Just to show you the contrast between what, pretty normal knee looks like on the outside of his knee, and then the inside of his knee is what's wreaking havoc and brought him to see us. Let's see. I think those are the examples I wanted to go over with you. We do have just post-operative expectations because it's a real common question and probably the most important question. You want to get back to work, want to get back to activity, whether you're an athlete or, you work for a living, have to get back to work, or you're a recreational athlete, whatever, we want to get you back. And so these are kind of average expectations, that we talk about. In general, if you have a rotator cuff repair of the shoulder, you're going to have about 8 to 12 weeks of physical therapy in general. There's also some good online programs that you can follow. It depends on the patient. Therapists are incredibly important. They're like coaches. Therapists can never be, we have to have therapists, but we also have other ways for people to be educated. So you can do some of your own exercises as well. But generally, you're doing some form of therapy for usually about 12 weeks. And then you are working on your own strength for about a year to get back to your optimal function. All these reconstructions, if it takes a year. It takes a year to get back because when you come into surgery, you're already compromised. You've already not done a lot. You're getting weak. You've lost motion in general. And so then after surgery, you have to come out of this pit and you've got to work your way up. And so to get your strength back, knees, athletes talk about it all the time. They go, "Doc, my quadricep just went to pot." And we're talking just a few weeks after the injury. It looks like it just atrophies overnight. It's crazy. And to get that quadricep back to anywhere near normal function takes a year. I don't care if you're, working with the best, NFL trainers in the world. It's going to take a year. But so you have to be aware that any injury does take that long to really get back, but it doesn't mean you'll need therapy that long. But generally, a couple of months you have to expect. Return to activity with most rotator cuff tears is from 3 to 6 months. If it's really a large tear like the one I had, it's going to take longer. But the simple tears that I showed you initially, 3 months patients are doing most things they want to do. 6 months, 90%. But again, full activity, we're still talking a year. The reverse shoulder replacements, since we're still talking about shoulders, is a pretty quick rehab because you're not depending on the rotator cuff to heal. With an anatomic shoulder replacements basically say that we're replacing the joint, but we're keeping your rotator cuff because the rotator cuff is good. We're repairing the rotator cuff over our joint that we just did. So the rotator cuff still has to repair itself to get your strength back. But bottom line, both types of replacements, reverse is a little quicker because you're not getting out depending on that, but most of them are the same. About 3 to 6 months to get back to most things you want to do. A year to get back to everything again. We always say a year. Knee scopes, very common issue, the most common surgery we do. We weight bear immediately. Of course, the first couple of days, is all about the inflammation and elevation and all that, starting exercises. Some people need therapy. A lot can do it on their own. Within 2 weeks, you're walking pretty well. You're on a bike. You could be doing an elliptical trainer. To get back to most things you want to do, including if you're an NFL running back, it's still going to take you 4 weeks, maybe 6 weeks to come back, even with great trainers. But in 6 weeks, you're doing most things you want to do. ACL, reconstructions or repairs, similar. Generally, it's going to be about the same, 3-4 months of therapy usually, and then full activity. Most activities within 6 to 9 months. Again, full activity about a year, that type of thing. So you have to have your expectations. You have to be willing to work. You have to be willing, of course, to do your post-operative rehabilitation and not get stiff. But again, with minimally invasive surgery, it allows for less complications, faster rehabilitation, less nerve issues, less swelling. Makes it much easier to do these cases in an outpatient setting. But like in all surgical specialties, it's really changed everything we do. People always have their nightmare cases of their grandfather that had the rotator cuff fixed, 40 years ago. It's completely different. I mean, they used to have these enormous incisions over the shoulders that looked like a saber, looked like you got in a sword fight. I mean, they were huge, and they take the whole deltoid down. In fact, some of the guys I was training with in the 90s, some of the older guys still actually use that technique. But you can just imagine the rehabilitation and the horror. Like, we look back and say, wow, but that was, state of the art back then. But we continue to get a lot better. So we want to basically take care of the soft tissue, not piss off the muscle that's around it. In the shoulder, it's the deltoid. You just want to take really good care of it. And you want to get in there and get out with the least amount of damage as possible. And with all joints, that's what we try to do. That is minimally invasive. That's why we do it. So opening up any questions or maybe patients of mine that either want to yell at me or discuss that they're going through rehab or anything. I'm here and Danielle's here. And you can also ask Danielle questions.
I don't know about that. Okay, we have a friend in the chat who mentioned always stretch well before windsurfing.
Oh my gosh, yeah. That's how I hurt my shoulder. It's too gusty.
We have someone that asked, can arthroscopy be used for bursitis?
It's a good question. Bursitis is, when we talk about bursitis in the shoulder, we do. Bursitis in the shoulder is the area between the rotator cuff and the bone on top. So it's this little space. It's not part of the joint. It's a space where when you raise your shoulder, it can do what we call impinge. So the tendon can go up and it can hit the bone. You can imagine throwers, or someone that works at a factory, just the multiple revolution cycles that you're putting through that. And so it gets irritated. So that's in the shoulder, we call that bursitis. And yes, if it's not getting better, if say your rotator cuff's okay, but your shoulder is not getting better with conservative means, we go in there, we basically clean it out. We call it a decompression. There's a little spur. The spur that we talk about in the shoulder generally is where this bone on the top sort of comes down. It's like a fender. You think about a bike and a tire. I always think about it as like the fender is rubbing on the tire. Like if you have a dent in your fender, it's rubbing on your bike tire. So what we've tried to do is get rid of that bump, get rid of that dent in the fender, and maybe even raise the fender away from the tire. That's a decompression to give you space. So it's kind of like putting a lift kit on your truck. You're trying to get that wheel well larger. You're trying to get that fender above the tire. So we do that a lot, actually. So that's a bursectomy. When we talk about bursectomies in, say, the knee or the elbow, we're generally talking about on the outside of the joint, but it's generally part of the skin. It's where a prominence is. Your elbow is very pointy. and it's very commonplace to get a bursa. Generally, when we take care of this surgically, we remove it because you have to remove a cystic lining. It's kind of like, it is basically a cyst. It has a lining that you have to remove so that the bursal fluid, which is basically edema fluid that builds up and fills that sac, you have to remove that sac or that lining for it not to come back. So that we call that a bursectomy in the elbow. You see it in the knee as well. Guys that do construction or tiling or stuff like that, or plumbers that get down on the knees a lot, like those bursas will form over their knee. And then same thing, we've got to remove the bursal tissue. That's an open procedure because we have to get to the cystic lining. But in the shoulder, it's a arthroscopic procedure. Yep.
Excellent. Thank you. We kind of touched on this, but if you have anything more to say, someone asked, is minimally invasive surgery usually followed by physical therapy?
Yes, knee scopes, I tend to leave it to my patients with knee scopes. Knee scopes, and it really depends a lot on the patient. I ask them if they want to have a coach, a therapist. Therapists are amazing in that basically it is. I mean, I think about it being an old athlete. Most of us orthopods are old athletes. Having a coach push you or watch you or see the way you're doing things is incredibly important, and nothing can take, nothing can do that job better than an actual therapist working with you. Now, for some, it's hard to go to therapy. So say your job or you've got a long commute, you don't have much time. And so there are a lot of good online programs. We have an app actually that we can help patients with where they can do their own exercises if they don't have the time. Therapies also can be expensive, of course, so there's that factor as well. Some surgeries, such as ACLs, in my practice, I want patient to be with a therapist because it's complex and there's different phases they really have to go through. It would be very difficult to self-rehab with an ACL. I can't see doing it, honestly. I'm sure someone out there has done it, maybe successfully, but I can't see it. I really want a good therapist to work with my ACLs and most of my rotator cuffs as well. Arthroplasty in general, it's a good idea because it is painful, especially knee arthroplasty. It tends to be a pretty painful procedure, even with the best minimally invasive techniques. It's the nature of the beast. It's better than it used to be, but it's still hard to make sure you're getting your motion, that you're working through your motion, to have a coach doing that with you, bringing through the phases of therapy, I think is absolutely mandatory with the total knee replacement. And the shoulder replacement's the same. Basically, I think most of my patients will absolutely go to a therapist. But yes, rehabilitation with minimally invasive surgery usually is extremely important. And whether or not you do it with a therapist or a self-program, usually it's a combination of both. Yes, to make anything, basically any surgery we do in orthopedics work, generally you have to do a rehab program of some sort to have the best outcome, there's no doubt. And so you have to be willing to do it, especially when I used to do a lot of total knees. I would say to the patient, look, I can put the best knee in the world, but if you're not going to be motivated to do it, then we shouldn't even start. Most of us have that conversation with our patients, but they have to be, internally, as we used to call it in sports psychology, you have to be internally motivated. You can't be externally motivated all the time. Now, having someone whip you, hey, you got to do this, you got to do that, that's external motivation. You don't want to have pain because they're gonna hurt you if you don't. You want to have it coming from in you that you need to do it, you want to do it. That is internal motivation. You cannot force a patient to do anything. It has to come from you. It's your knee. We can put a great knee in you, but if you're not going to do the work, don't get it done. It's not worth it. You got to be willing to do it. If you're not willing to step up and do it, then come back at a time when you're ready to do it. So it's extremely important, both mentally and physically, and have the time set aside that you're going to do it. If you're going to do total knee replacement, that's what we say. You have to have the time set aside. You're going to do post-operative good rehab for a few months to get a good result, especially a total knee.
Fantastic. So we just got a question that came in. What is the success of fixing arthritis in the shoulder? Like success expectation?
Yes, no, that's a great question. There are shoulder replacement technology is just boomed. It's phenomenal. But still, it comes down to basically, is the patient willing to do what they need to afterwards? There are many different types of, when you talk about arthritis in the shoulder, there's erosions that can happen. In other words, your cup side, we call that the glenoid side, can erode in different ways, where your bone is really worn out in one place and not the other. So there are many different things that shoulder surgeons do to make up for those defects in the bone. So the bony defects plus the soft tissue sleeve that you have around it. That's why you have to know, if you do an anatomic shoulder, you have to have a good rotator cuff. It has to work well. If you do what's called an anatomic shoulder, which is basically, replacing a ball for a ball and a cup for a cup. That's what we call an anatomic shoulder. Some of the best technology, however, really has gone along with reverse shoulder replacement. Reverses used to be done in very few patients. They've chosen very carefully, but now more and more reverses are being done because the systems are very good and the indications have expanded. That's all part of the evolution of shoulder replacement, which, like all branches of medicine and surgery and orthopedics, shoulder replacement technology has just boomed. But basically, some of the greatest thing about shoulder replacements is they're almost always done now as outpatients. That's great. So it's always usually done in a center. It's very efficient now. Many surgeons are trained in it, where there weren't many 20 years ago. They were trained well in it. Now many surgeons are trained well in it. Excellent fellowships for trained surgeons. So and I can't give you a number for success because every patient's different. And I know it's kind of a cliche to say it, but it's the truth. Every patient's different and it depends on so many things. But again, getting back to the motivation of the patient and your mental state when you get it done, and if you're willing to do the work, is absolutely a prerequisite. After that, sure, you want a good technical surgeon that's experienced. But yeah, it's getting better and better. I can't give you a number though on it. It's very successful.
I said thank you. And then I think the last question we'll do, unless someone else pops in another question, it's a two-pronged question. So what does the follow-up process after surgery look like? And what should I look for in a good minimally invasive surgeon for myself?
You got it. Let's take a knee scope, for instance, our most common one we do that we say minimally invasive, or most common knee scope type of thing. Most surgeons, most of us are pretty well trained in just doing debridement scopes like the cartilage one that I showed you. A good ACL reconstruction depends on the program. A lot of good non-fellowship trained. By the way, fellowship in training, it's the same with all surgical specialties, whether it's general, OBGYN, whether it's us, ENT. There's all these, we all have fellowships. Fellowships, it just means extra training in a certain focus. In orthopedics, sports fellowship is a very common one. So they do an extra year with just a focus on sports. So they do a lot of ACLs. So fellowship trained surgeons more and more become surgeons that patients get sent to because their experience level is great. Now, there are a lot of programs, including the one I was in the Navy, where we did a lot of sports. We had still one of the best surgeons, and my mentor that I've ever known, Dr. Atkinson, taught us from the very beginning. And he was some of the first to bring in all the new technology with the different anchor systems and things like that when they came out. So you can have programs that really are strong in sports in general, and a lot of those guys coming out don't feel a need of fellowship. It's hard to say. When you talk about reputation of a surgeon, experience of a surgeon, you definitely, if you're worried about their experience level, you should ask the surgeon, how many of these have you done? And they can usually now get most of your information where you trained off the internet. So a lot of times we don't have to go over, back in the old days before internet, patients would ask us, we'd have to go through it. Oh, I went here, went there, and we'd sometimes give little brochures out about ourselves because we didn't have the internet. Now you can find out everything about us. And, but as far as, how comfortable do you do, what type do you do? Feel free to ask them that. ACL, for example, there are a million ways to fix ACLs. There are a million ways to reconstruct ACLs, many different tendons, whether it's from whether it's from a cadaver. it all depends on you, the patient, your activity level, your age, where you want, if you're doing it at a surgery center or a hospital. But what to expect with different things. Knee scopes, again, very simple. Most of my patients are back to their normal activities within about 6 weeks. ACLs, though, if they expect, and this is true if you're an NFL quarterback or whatever, you're out with an ACL, you're out for the season, of course. And you're coming back for that, next summer, working out for the next year, but it's still a little early. About 9 months after it, those guys are still wearing braces. I mean, they're not 100%. When a quarterback, he hurts himself in September, he's out. To get him back for the next season takes a lot of hard rehab. We're talking the best trainers, anywhere working with these guys. So your expectations with most things, even minimally invasive, I always say a year. Knee scopes are simpler though, so it's quicker. But in general, any type of reconstruction is about a year to get back. Yeah.
Fantastic. That is what we have for tonight's webinar. Thank you guys so much for coming and being engaged and asking awesome questions. If you'd like to know more, you can visit our website. We have all the information on our screen here. And we'd love to see you if you want to come in. Just have a great holiday season.
Great holiday season, everybody. And come see us if you need us. We'll love taking care of you. Hope you don't get injured. So don't come and see us.
Yeah.
Just don't get injured. It's the best thing. But if you do come and see us, we have a bunch of different subspecialists, and we also have excellent interventional pain doctors, as well as fantastic podiatrists and very well-trained physical therapists in many locations. So come and see us if you need us, and have a great Thanksgiving coming up. Thanks for spending your night with us.